thanks for passing those into the center, and we'll collect them. I'll ask the first question, and it's on the opioid epidemic. And whoever wants to, probably for Dr. Flood. With so many opioid overdoses, an estimated 150 doses per day, are there any case reports of fetal neonatal harm or demise?
Can you read the last part again? Fetal?
Any cases reported of fetal neonatal harm or demise with the, when they go overdose?
Opioids? There are definitely pregnant women who have died of opiate epidemic, through the opiate epidemic, absolutely. You know, increasingly we're thinking what we can do about the opiate epidemic, and by and large, you know, Dr. Carvalho talked about a lot of it using non-opioid based techniques in our work, but it really has to come from beforehand, because, you know, women aren't dying so much afterwards as, you know, during their pregnancies.
Okay. Anyone else from the panel? Okay, next question. Can you address the use of ketamine during a cesarean section to supplement analgesia in the event of a patch epidural? Does the low, how about that for Dr. Carvalho? Use of ketamine.
Yeah, so when I mention ketamine, it's sub-anesthetic doses for analgesic effects. And the doses that have been used are 10 to 15 milligrams, often with a general anesthetic to supplement it, or patients undergoing cesarean under spinal or combined spinal epidural. So it's purely an analgesic sub-anesthetic dose. When you're using it for treating inadequate blocks, it absolutely is one of the drugs that I would turn towards. Again, you've got to be aware of how much you're giving, but more because of safety of mom as a airway that you don't have control over. But it's something that you should absolutely use, and it's your bigger problem than breastfeeding concern at that point in time. So it's definitely a drug that I use commonly in that situation. I'll just remind you that the problems usually you know about before, so getting the block to work and checking it adequately before you start being more important. And remembering that if you do not have a block or an adequate block, offering general anesthesia, we tend to struggle for too long often with sedation techniques like ketamine. I don't know if others want to make comments.
And there's a follow-up too, Brendan. Does the low volume of colostrum at that time allow for safe use of ketamine in this setting?
Whenever you're treating a pregnant mom or postpartum mom, you must always remember that the most important patient in front of you is the mom. So I wouldn't be concerned because of potential fetal or breastfeeding concerns. So that wouldn't influence my use or lack use of a drug that I think the mom would benefit from. Again, it's going to work on simple pharmacokinetics. Drug's not going to last very long. The breastfeeding in the initial hours are really just to start the process, but nothing is really coming out initially. Again, so you have an even bigger safety net for using ketamine in that situation. Where I say there's a bigger concern is if you're running infusions of it postpartum, which you may require in chronic pain patients where you're really struggling to control their pain, but Pam can talk more about that.
Okay, this question is for Dr. Butwick, who was speaking on promoting neuroaxial label analgesia service. What are your current thoughts on the use of nitrous oxide?
Oh, how about that? Okay. So there's definitely a lot of interest out there in the community for nitrous oxide, and we're fully aware of that at Stanford. So much so that we actually introduced nitrous about a year and a half. Well, it's more than 3 years ago now. God, time flies. So we have nitrous available because we knew that there was a demand for it. We have to be mindful about the fact that even though the data suggests that it's probably providing modest to moderate analgesia at best, that doesn't necessarily mean that patients aren't satisfied with using nitrous oxide, especially if they want that childbirth or natural childbirth-like experience. So we have it out there. We have it out there on our labor and delivery unit. It's definitely an option, but we have to be very sensitive about patients that, especially the primates that want or are aiming for a natural childbirth experience. they try nitrous, and if for whatever reason their pain breaks through despite having nitrous, and they request an epidural, my key approach when I go in the room, especially with residents, are be sensitive and be sympathetic, because some of these patients psychologically feel like they've let themselves down if they end up requesting an epidural, and that's certainly not the case. So we're often very mindful about the psychological impact of a change in their birth plan if they wanted nitrous and they end up getting something else.
Alex, prevalence at Stanford, use of nitrous now?
Yeah, we analyzed about a year or so of data, and it's just under 5%. So we have a very small utilization. It's more an analgesic option. 2/3 of those who use it go on to get an epidural. And what's a little different how we approach it to how UCSF approaches it, it's an extremely safe drug that could easily be administered by midwives and nurses, but we keep ownership of it, partly because we want to make sure that the information that's imparted to women when discussing analgesic options is neutral and balanced. They get a chance to meet us, so the epidural becomes less threatening later on because you establish a relationship. So we really emphasize the fact that this is part of an analgesic option, and our EPIC build is very much geared towards already starting their labor analgesia as part of their nitrous oxide. So when they convert to an epidural, we already have a continuum going on. So that's why we've kept ownership for it. There was concern that we would erode our epidural service, which hasn't happened. I think you probably generate a few extra clients by virtue of introducing yourself, and a woman who feared anesthesia and fears it less because you establish a relationship. But you do lose several hours of nitrous use that you could be using an epidural, so they probably offset each other. And we feared it to some degree, that it would erode our epidural service. It's actually complemented it really nicely.
Yeah. The other thing to bear in mind, Brendan mentioned this just now, is that patients, when they found out that we had nitrous available on a labor and delivery unit, they wanted to come to Stanford specifically because there was nitrous availability, where they may not have had that if they'd gone to some of our local competitors. So when the word got out, again, we liaise with our OBs, because obviously the OBs are really important in communicating the types of pain relief that patients receive or can receive at Stanford before they see us. So when the word got out that we had nitrous available, that may well have made a little dent, may well have increased the number of patients that we had coming through our labor and delivery service in terms of volume.
Sorry, I know I'm dominating the mic, but I have to tell you a story. I got a call from someone asking about which vendor do we use, what protocols, could we send it, could we share it, and I had a very nice conversation, and then I said, well, where do you work? It turns out she's a patient, I kid you not, pregnant patient, who was delivering at a Bay Area hospital that didn't provide nitrous oxide, and she was looking for a vendor to buy her own machine to bring it in for a delivery.
Okay. This is for Dr. Flood. How about patients on Suboxone or buprenorphine? Is an epidural okay? Can you use it with fentanyl IV? And are IV opioids okay after a cesarean section?
Great question. So in terms of an epidural is completely fine. There's no interaction. In fact, an epidural is really the best thing to do as quickly as you can for people on Suboxone. In terms of postpartum pain relief, that can become more problematic because they're very tolerant to opioids. And buprenorphine's a partial agonist. So basically, you just have to understand that the best thing to use is to use multimodal techniques that they won't be tolerant to. Particularly, this is, we mostly post-cesarean section rely on Duramorph, but in that setting, I'll leave in an epidural and continue at postpartum because that's really the best way to control the pain.
Okay. And how about using it for breastfeeding, Dr. Carvalho? If they're on Suboxone, buprenorphine?
Again, Pam may know the data better, but I'm not aware of any breastfeeding studies of breast milk transfer. You would expect it to behave similar to other opioids with similar transfer ratios.
Yeah, that's an interesting question because patients, particularly on methadone, can be on very high doses that can be transmitted to the fetus, but still the American Academy of Pediatrics recommends breastfeeding in mothers on buprenorphine and methadone.
Just from a planning standpoint, hearing about these patients early from our OB colleagues is really important because you can formulate your plan for pain relief during and after labor and delivery early, so that can alleviate a lot of anxiety that patients have if there's no plan that's put in place by the time they go into labor or have their C-section.
Yeah, I have kind of an interesting niche market here because I get sent from the OBs a lot of patients that have chronic pain or on chronic opioids to my pain clinic, and we come up with a plan throughout their pregnancy, and that's really the most important thing. So find a pain management doctor that you can liaise with and come up with joint plans.
Okay. Move on to Dr. Butwick. This is more about an ERS protocol for cesarean sections. Can you speak on an analgesic approach? And is there a specific ERS protocol for post-cesarean analgesia? And what if they're on opioids?
Probably Brendan's a better person to answer this question, but we have a standard protocol at Stanford that we use for our cesarean sections with standard order set. We can modify that set depending upon if the patient has any concern about pain management that we're aware of beforehand. Do we have an ERS protocol at Stanford? No, but we have talked about it, and Brendan could probably chime in a little more about where things might go with that. And I think it's not just a matter of having an ERS protocol, but we've talked in the past about having a peripartum home, where you're working with OBs, pediatricians, nurses to establish a whole protocol that allows the patient to come into the hospital, have great quality care, has a good experience, and then hopefully can limit the amount of time they're spending in the hospital if other things otherwise go well. So there's quality advantages and cost advantages both to the hospital and the patient if there's a home model that we can apply. Now it's a great concept. Trying to action that is a whole different problem in itself.
Just to expand a little bit, I see Eric Hunt's here, who's set up ERAS for Northern California Kaiser. We have few challenges on that, and it depends on how you define ERAS, and is it the complete package, like Alex mentioned, the perioperative surgical home. We do have it in a way that we cover all aspects of anesthesia care, from fluid to pre-op optimization, fluid management, temperature management. We control all the analgesias throughout their stay. What we failed in doing is getting the home together, getting OBs and lactation consultants and nurses all, as well as an outreach, but it is slowly happening. So we pushed as much as we could on our end, which I think a lot of you will struggle with then convincing management to change. And what eventually changed the thought processes was pressure on the beds and external forces, but it wasn't from our end 5 years ago pushing for ERAS. So again, it depends on how you define ERAS. Is it a clinical pathway? Is it a little beyond that, or is it the full home? And I think we all have variations of how much we offer for that.
And Dr. Flood, what about if they're an IV drug abuser in ERAS? Any comments on that?
I'm sorry.
IV drug abuse and with the history and being pregnant in ERAS.
It's interesting. We don't see as much of that at Stanford, thankfully. But mostly patients who are IV drug abusers, the obstetrician will have referred them to MFM, and they try very hard to either get them on methadone maintenance or Suboxone. But active IV drug abusers, of course, have all the risks of opiates that they may or may not be actively using, and their tolerance, plus other drugs that they might use. So really the key with active intravenous drug abusers is getting a tox screen and knowing actually what they have going on.
Okay. Is there an increase in intrathecal dose of Doromorph if they're methadone users?
That hasn't really been well studied. We did do a really interesting study that has it come out yet? Hasn't quite come out yet, but it'll come out soon, where we simply asked patients how much pain medication they thought they would need, in a way kind of like the joint decision model for outpatient pain medication. And then patients were able to choose a low, moderate, or higher dose of intrathecal opioid. So patients actually who thought they needed more actually did have more pain, and it was somewhat mitigated by the higher use of opioid. So in patients who are at risk for more pain, I do use more, but we haven't looked at that in a randomized way.
Okay. And this could be to any one of the three. What about the management of patients on regular use of marijuana? And does the use with nitrous in such patients add an additional risk? And what about smoking marijuana and breastfeeding? So marijuana per se coming in.
So I don't know if any of you have read, ACOG has dabbled in making statements about this, and the reactions to their statements is quite interesting if you read about it. It's becoming a way of life, especially in states that have legalized it. I think you're going to see more and more of it, and I actually think it should be studied as a potential analgesic option in labor. No reason why not, if someone's prepared to do that. We have little experience using it therapeutically. It's more recreationally. So you're not going to get much
Are you speaking
information.
for yourself, Dr. Carvalho?
What are you talking about?
Yeah, I know nothing about this.
No, nothing about it.
I just wanted to say, as a pain management physician, it's really problematic because there are instances where there actually is very good evidence that THC or some of the other metabolites that are found in marijuana are very helpful. But the fact that it is, federally illegal in the same class as heroin, it can't easily be studied. So there's just not a lot of data out there.
Okay.
The other thing I'd probably
Oh,
want
yeah,
to
sure.
do if someone comes in who is claiming that they do smoke on a regular basis is probably do a full tox screen, as Pam mentioned earlier on, because it's possible that they're taking other recreational drugs on top of that. So you want to make sure that you're not getting into a problem that's actually deeper than you might think.
Okay, and the next question, that could be whoever, is Precedex. How about using that for labor analgesia? Dexamethasone is part of multimodal analgesic, and what about in breastfeeding? So how about dexamethasone just for pregnancy, labor pain, and then dexamethasone in breastfeeding?
You're a tough crowd. So it is certainly a drug you can do for sedation, and it's in the same family as clonidine. If you take our lessons from clonidine, I think, again, it's a moderately effective analgesic. If it's used neuraxially, it's not a game changer. It's something that can be considered in certain high-risk patients or chronic pain patients. There are a few studies with dexmedetomidine descriptions, but it's not well studied, and also very limited data on breast milk transfer. And I'm sure Pam will.
I don't see any benefit of using dexmedetomidine neuraxially over clonidine, where there's so much more information.
Okay.
There are also some case reports of using it for chronic pain patients for anesthesia, analgesia afterwards. But the problem is the sedation and the hypotension, so that's really the dose-limiting factor.
Okay.
And I don't think anyone studied it in breastfeeding.
So would you feel that maybe remifentanil might be a better alternative than dexamethasone?
For labor or
Yes,
for section?
for labor.
Well, there's certainly
Analgesia.
a lot more known about remifentanil. So, yeah.
Okay. And this will be the last question, because we're getting close to coffee break, is the role of tap blocks in C-sections and being IV drug abuse.
So I touched on some of the data of meta-analysis. So the role in non-drug abusing patients is that it doesn't seem to have a analgesic benefit when added to a multimodal technique, including intrathecal morphine. So it should be reserved for routine care in centers that don't use intrathecal morphine. It has a role for breakthrough pain. When you're thinking of patients who are difficult to manage pain, chronic pain patients, I personally don't think it's reliable enough, and the duration is limited. You really are only going to get about 6 to 8 hours of analgesia. So you have to use a catheter-based technique, and there's no studies of catheter-based technique tap blocks after C-section beyond just a case series. So my personal preference would not to be use tap blocks in that setting, but to lean towards neuraxial, so epidural-based technique for these patients.
I think the other challenge is unless you're doing, on top of it, I agree with everything that Brendan's just said, but unless you're doing tap blocks on a regular basis, so if you're doing a lot of regional, or if you have to be facile in the block, that's great. But if you do it if you rarely use these blocks, I'm not sure if I would be necessarily comfortable in doing the block myself. I'd lean upon my regional anesthesia colleagues if I felt that there was a good clinical indication for using it, depending upon the acuity of the pain after C-section.
Okay, so we'll call an end to this session. We have a coffee break from 9:45. We'll see you at 10:30. Please visit the vendors if you get a chance.